Good morning, everybody. Bereshus Rabbi Rosenbaum, who's going to be our host on behalf of Young Israel Maimuna. Welcome to Understanding Vaccines, the Promise and the Process. My name is Max Rudman. Today's program is part of Bikuchli Greater Washington's health education effort, which is co-sponsored by a number of local synagogues in Silver Spring. We have run other programs relating to COVID in the past few months, and we expect to do more. After 8 months of isolation, recent good news about COVID vaccines may help us get together again when there's enough supply and logistics have been worked out for who gets them, when, and how. That's not going to be the focus of our program today, though. Today, we're going to take a broad look at vaccines and infectious diseases. Our thinking about those has changed a great deal. Across the United States, both the rich and poor live with little concern for many infectious diseases because of the great effort and sacrifice has been made to develop and implement vaccination programs. For years, we've lived free from the fear of illness from what were formerly endemic killer diseases. As the COVID plague reminds us, maintenance of that freedom depends in part on remembering what has gone before us, removing the barriers that remain in affording access to safe and effective vaccines for all people, and using science to discover ways to prevent other diseases we have not yet conquered. The promise of vaccines requires a well-functioning public health system to oversee the complex effort to deliver the vaccines. Our program today looks at some of the actors involved in developing vaccines and getting them to us. The insights gleaned today can help us learn what may lie ahead and our part in it. We go first to the lab bench, as it were, to learn how scientists engage the body's immune system in pursuing vaccines as a response to fighting disease. Next, we're going to look at where most vaccines are administered, the pediatrician's office. That's where a seamless process has been in place for many years that protects millions of children from the ravages of terrible diseases. Third, how do you get a child, much less an adult, to agree to be vaccinated? Public reactions to vaccines are usually quite strong, varying from awe of a seemingly scientific miracle to doubt and outright hostility. Beyond the far-reaching discoveries that transformed the making of vaccines over the past century, more and more vaccinology has been shaped by regulations regarding research on human subject research and enforcing safety standards. A well-functioning public health system makes a number of assumptions about how we will respond once vaccines are available. And finally, what insights does Jewish law offer about vaccination? An important benefit of vaccination is creating a herd immunity or population immunity in which a population can be protected from a certain virus if a threshold of vaccination is reached. Does halakha obligate a person to protect themselves and others to help create herd immunity? Must a parent vaccinate their children? May governments and private institutions compel vaccination? A little bit about our speakers, all of them living in our wonderful community. Dr. Jonathan Schneck received his MD, Ph.D. in immunology from the Albert Einstein College of Medicine. After completing his degrees, Dr. Schneck trained in pediatrics at the Children's Hospital National Medical Center in Washington, D.C. From there, he went to the National Institute of Allergy and Immunology at the National Institute of Health in Bethesda, where he did his postdoctoral training at the Laboratory of Immunology. He joined Johns Hopkins Faculty of Medicine in 1990, where he's currently professor of pathology and medicine oncology. He received many awards, including the Mellon Clinician Scientist Award, Harry Weaver Neuroscience Scholar Award, multiple Myeloma Research Foundation Scholars Award, and recently a gift for his groundbreaking grant for work in cancer immunology. In addition, he's actively involved in teaching and leads the Genes of Society Immunology course at the School of Medicine. He's also on the board of editors of the Journal of Clinical Investigation. Dr. Schneck's work has focused on understanding and manipulating the white blood cells, which are the forefront of immunology for our system, for our body. He has developed, patented, and licensed several products and has worked closely with biotech startup companies. He has received grants and receiving grants from NIH. He is at the cutting edge of many immunotherapies tactics going on these days across the country. Dr. Lynn Trombka attended medical school at the University of Maryland, Baltimore. She did her residency in pediatrics at Georgetown University Hospital, completing it in 1992. She has happily worked for Kaiser Permanente in the Department of Pediatrics. In addition to her work as a general pediatrician for the past 10 years, she has been a preceptor, the word teacher, for pediatricians doing their residency at Children's National Medical Center. Next, Dr. Eliot Fishman, or Ellie Fishman, is the Senior Director of Health Policy at the healthcare advocacy organizations called Families USA, where he leads policy analysis and advocacy agenda development at the state and federal levels, and he works a great deal with policy departments and other members of senior leadership. He has worked on issues relating to universal coverage, transformation of healthcare delivery and payment, and achieving equity in healthcare access and outcomes. Prior to joining Families USA, Dr. Fishman served at the Centers for Medicare and Medicaid Services from 2013 to 2017. In that role, he led the federal government's work with states on Medicaid waivers and federal policy on the Children's Health Insurance Program and Medicaid quality measurement, eligibility, and enrollment. Finally, Rabbi Dovid Rosenbaum has served in Washington Rabbinate for 20 years, the last 15 at Young Israel Shomer Emunah. He encountered the full spectrum of issues that pulpit community rabbis tackle with large congregations, many involving health issues. Over the past several years, he has supported health education programs, and he has shared insights drawn from Jewish tradition and halakha on a wide range of the topics we have tackled, including mental health, fertility, caregiving, and end of life. We will have a questions and answer period at the end of the presentations. I will serve as your moderator. Please send your questions through the chat function, and we look forward to getting your questions and answers in your rapt attention right now. We first turn to Dr. Schneck. Thank you.
Let me unmute myself first. All right, give me a sec.
We can hear you now.
You can hear me now. Great.
Yes.
Okay. Wonderful. So let me first thank Max Redman for organizing this and hopefully ensure informative session. And of course, the Bikur Cholim and of Greater Washington, Young Israel Shomer Emunah for sponsoring it, and the co-sponsors, including, of course, my own shul, KMS, and the other organizations that have stepped up and helped co-sponsor this. Let me dive into to the talk, and again, thank Max for the very gracious introduction. I appreciate it very much. Let me dive into the talk and make sure that you can see my screen, which should be now full screen Zoom, hopefully. And have about we're going to try and run through, and I'm going to try and give you some of the basic principles about vaccination. But Max and I have had this discussion, and as he knows, my view is a lot of this is ultimately about COVID as well. And we're going to spend a little bit of time on that. What we cover in terms of general principles, that'll be great. But also, I think this is the topic of relevance at this point in time. So let's talk about vaccines as an overview. And my goals are to talk about the impact of vaccines that have on public health, the principles of immunizations, the types of vaccines that we have, advantages and disadvantages of each vaccine type. And that's an ambitious set of goals for about 18 minutes. And Max, I have set my timer, so we should be in good shape. So vaccination has had a critical role in reducing the mortality and morbidity associated with infectious disease. It's actually been the major impact in terms of infant mortality that we've had over the past 100 years in terms of vaccinations. It's prevented about 103 million cases of contagious diseases in the US just since 1924. Since 1924, there wasn't a lot before that. And globally, it prevents about 2 to 3 million deaths per year from diarrheal diseases, from measles, pneumonia, polio, whooping cough, and other infectious diseases. And it also, in the process, then can support broader gains in education and economic development because less resources need to be addressed towards these other problems. Now, I'm not trying to minimize. There's still plenty of of global health problems such as diarrheal diseases and others that need to be dealt with, but it certainly has supported broader gains in education and economic development as well. So not just the ones classically associated with the vaccine itself. The impact of vaccines, our coverage with most vaccines is among children. That's where our biggest impact has been, from 19 to 35 months. It's stable, and 70 is stable, and greater than 90%, between 70 and 90% dependent on the vaccine. And we're not going to get into the details of that, but we know that some of the vaccines like flu are not quite as effective, and some of them, like the childhood vaccines, have greater than 90% efficacy. There's a small but increasing proportion of children receiving no vaccines by age of 24 months, and that's a very big topic from a medical and health perspective, and political as well, and I'm certainly not going to try and address that issue. Fewer than 500 children, ultimately though, fewer than 500 children die annually of vaccine preventable disease illnesses in the US. So that's like the huge impact in terms of what we see, and again, support for the idea of using vaccinations. The vaccine rate in adults over 65 has increased, but remains below the targets for all vaccines. And those are going to be for things like shingles and for flu and other diseases. I just would like to start, I know there's a pretty gruesome picture, but the impact of vaccines, the very first vaccine, is in terms of smallpox. And these are a picture of some infants that died of smallpox. So, and I think smallpox is a wonderful example because it killed 300 million people worldwide in the 20th century. It's highly contagious, and the mortality rate was super high, 30 to 50%. And survivors were sometimes blind and virtually always scarred. Those of us who are older can look at our shoulders and know that we've been vaccinated for smallpox, and those of us that are younger have not been, because it's been eliminated. The reason it was eliminated was the groundbreaking work of Edward Jenner, who realized what was going on in terms of polio and in terms of smallpox, and how he could use cowpox, a related virus, to impact on the smallpox infection. Here is an example of here's the data for the global number of smallpox cases, and you can see it was declared eradicated in the late 70s, early 80s. So that's a fantastic story, and we should have others that are like that. These are other diseases that were once common in the US: measles, mumps, congenital rubella, again, smallpox, tetanus, and diphtheria. And here are the statistics behind those now, and how they've been impacted on both by other public health policy issues, but also by vaccination rates. And you can see just made major inroads, certainly in the US, in terms of all of those diseases, and worldwide as well, but this is the data for the US. Okay, so what I want to do now, with that as a little bit of a background, is talk about immunology. I promise at the end of it, I'll wake you up. If you've fallen and hurt your head, I'm sorry. But to talk about immunology, I have to start with this slide. So I need there's a whole language to immunology. And my wife can attest to the fact that one of my focuses now is educating people about that language and educating other scientists. So, and here you can see I need a 4-letter word for immunology. No such thing exists as a 4-letter word for immunology. But what often comes up happening is that blah, 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 blah. And because we have our whole different language. Now, Max was very kind to go through my slides and point out where the blah, 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 blah is occurring. But if I, by chance, default to immunology lingo that you don't understand, then put it in the chat, raise your hand, let me know, and I'm happy to explain it. But I do want to point out that there is a whole language associated with it. You're probably more sophisticated in it than you ever thought you would be because of COVID, but I'm sure there will be things that I'll say that won't be 100% clear. So let's talk about the principles of immunization and the different types of immunity, that we have. So there is a passive immunity. We'll start with passive immunity, and that's by something that are called immunoglobulins or antibodies, another term for that. The goal of passive immunity is to provide short-term protection. And the means of protection is that the antibodies, and sometimes we abbreviate that as AB, from an immune adult or animals, or an animal is given, and since it's acute and it's short-term, there's no boosters, and it does offer immediate protection. And for anybody who's had hepatitis and had a child, that's part of what's given right before, or also in terms of RH to protect against RH immunization and RH sensitization. That's a passive immunity, and something that people probably know about, certainly the RH factor issue. There's also not only passive immunity, but what a lot of people are focused on at this point is, of course, active immunity. And active immunity, is we give vaccines, or we give parts of toxins that don't cause a toxic response, but they can then help our body elicit an immune response that then provides protection. So in the passive, what we've done is we've taken other people's immune system, their antibodies, and give it to somebody who's at high risk, or a child who's at high risk. In active immunizations, we have vaccines and toxoids. They provide a durable immunity. And the way that they work is by now, when I get a vaccination, is by stimulating my own immune cells to respond. And that is a general sort of thing, but the way that we measure those responses are by the cells proliferate. They like to divide and become more cells, because what we've told the immune system is, hey, those cells are really important. So you gotta wake up, you gotta get off the couch. If you're a couch potato, you gotta get off the couch, you gotta proliferate, and you gotta do what you're supposed to do. And that's what we call differentiating. Now, when we see that, we hear that on the news, it's B cell proliferation and antibody production and T cell and stimulation. Are boosters given? Sometimes they're given, and sometimes they're lifelong. And do they offer immediate protection? No, they don't offer immediate protection, but that's why you give it, and then and you may even have to give a booster for it, and then you're protected for a certain period of time. Hopefully very long, but sometimes, like with flu, we need to be vaccinated on a yearly basis. The features of a safe and effective vaccine are that they shouldn't cause, of course, they shouldn't cause illness or death themselves. The vaccine has to protect against the illness resulting from exposure to the live pathogen, the live virus, the live bacteria, whatever that pathogen is, just a general term for that. And the protection should last, hopefully, for several years, although not always. And some induced neutralizing antibodies. Again, we've heard a lot about that in the news now, also with COVID. But the diseases such as the vaccines for polio produce antibodies that then make sure that polio doesn't infect other cells. And neutralizing antibodies is essential to prevent infection. That is, again, a term that you're hearing now in the general news media as, oh, we're looking not just for an antibody response in terms of the COVID response, but neutralizing antibodies. Now, for any of those who know me, know that I love and adore protective T cells, and I don't really like antibodies, but and we get a little bit of a plug for protective T cells. They're also important. It's not 100% clear that it's just the neutralizing antibodies in terms of COVID that are going to be important, but it may also be the T cells, and that's a general sort of statement, a general sort of pitch from my perspective. Practical considerations, of course, are clear: the cost, the biostability, the availability, and of course, few side effects. And I'll spend time talking about that as well. So our goal in vaccination is to develop long-lived immunologic protection via introduction of a modified pathogen, a modified virus, or components of the pathogen that are remembered. And that's a critical thing. Immune system, one of the unique aspects of the immune system is memory. So that once I've been exposed to it via vaccine, if I'm now infected by the pathogen, by the virus, I remember that I was vaccinated to it, and my immune system can mount a very fast response before the virus has a chance to take hold and set up house and hurt me or hurt you. This leads to enhanced memory. Again, that's an immune system nomenclature, this idea of memory that once I've seen it, I can respond to it quicker, that are either completely prevent infection or generally reduce the severity of infection. And that's our goal, to reduce the severity.
And others in the family as well. And I'm going to read out the instructions.
Dr. Schneck, let's postpone your questions until the end. Let's postpone the questions until the end, okay?
Jonathan, if you just unmute yourself for a second.
Oh, sure. Was I muted?
No, I did it. I did it for a second. It was me. I'm
yes.
sorry.
We'll hold on the questions till the end. Sure. You're the moderator. Major types of vaccines, the whole killed vaccines. This is some flu vaccines are like that. Polio, some of the polio vaccines are like that. Live attenuated, also the oral polio is like that, the MMR, and some influenza vaccines are like that. Subunit vaccines, the hepatitis B vaccine, which we've all had, HPV, Gardasil, which I'm sure most of us have had, and Haemophilus influenza. Now, antigen-bearing vectors, hey, what's an antigen? And again, I said I try and pick up the terms, but that's just stuff that the pathogens make and that we can recognize in our immune system. Okay, so let's talk about why we're here today, in part. And of course, part of that is going to be the COVID vaccines. And I'm going to take a few minutes to just talk about that, and then we'll go back to the general vaccines. So both Pfizer has now put in for FDA approval of their COVID vaccine, and in a similar fashion, Moderna is about to put in for theirs as well. Those are subunit vaccines, and we'll talk a little bit more about that. An antigen-bearing vector, you've heard about the AstraZeneca Oxford one, that's of that category of an antigen-bearing vector. So what the two first COVID vaccines look like. And it's shocking literally to anybody in the field to envision that, oh my gosh, here we are. They look so similar, they're quite different, but they have lots of similarity, and they have greater than 90% efficacy. Nobody expected anything like that. So what's the story with them? So they're nanoparticles, means they're very, very small. They both deliver genetic material. For the Pfizer one, it requires super low temperatures for storage, -70 to -90, which we do standardly in the lab, but your physician's office will not have that. And the other one, the Moderna, has more standard storage requirements. The material in both of them is genetic material called RNA. So we all have DNA. Our DNAs are then made into RNAs, transcribed into RNAs, and from there we make the proteins. And they both target the spike protein. And protection certainly appears to require antibodies, if not solely mediated through antibodies. And of course, this is a picture that everybody has seen 1,000 times a day probably, is the picture of the COVID virus, and the spike protein is this red guy sticking out. And the spike protein is what allows it to attach to cells and to infect them. So the antibodies cover that spike protein and prevent that infection from occurring. And that's how it occurs, by preventing that infection from occurring. And I hope to never see that picture again on TV, but I suspect we will for a long time. So how are they done, and how are they done so fast? Vaccines usually take years for development, often close to 5, sometimes 10. So this is a little bit of a pitch, and Michelle told me not to make it too long, but it's really based on previous basic research. We could not be here without the previous research. And believe it or not, it was on viruses that people in the US, that we in general in the US, could give a hoot about. Really, who cared about MERS and who cared about SARS? That really got to the US. It wasn't really important from our perspective. Obviously, it's very important from the Chinese perspective, but there was a lot of development of the MERS and SARS vaccines. And what it actually showed was there are, in this spike protein, there are 1,200 amino acids. And again, I'm not going to get into the size of amino acids. They're very small, but there are 1,200 amino acids. 2 of them needed to be changed. So 2 out of 1,200 were changed, and that allowed the spike protein to be stabilized. Okay, without that, so that was baseline. So everybody knew that we had to start there with those two changes. And there are the specifics are there two proteins that needed to be changed, doesn't matter. But it is that we already knew about two of them that needed to be modified. And that allowed us to start from a position where we could have a stabilized protein. So without the studies on SARS and MERS, which again, I would tell you the American community doesn't really care about, it would be impossible to be where we're at. The other thing, how is it that Moderna's vaccine is stored in, minus regular freezers? And they spent years developing the nanoparticles that were stable. Pfizer was never into that before, and so that's why theirs requires that sort of stability. But Moderna spent years developing that for viruses, for vaccines that have not been particularly successful, but they knew about how to store the lipid nanoparticles. Yes, but are they safe? So if the studies often take up to 5 years, how can we be sure? So one of the things is that the process, I'll skip to the third, the process is identical to other vaccines. And we have to trust and believe in that process. And the truth is that I do. And that, if they had it tomorrow, I'd roll my arm up, my sleeve up, and I'd be happy to take it. We have experience with 70,000 volunteers now, and that's an impressive amount of volunteers. Why did we have so much? Why do we have so much so fast? Part of that, certainly with the Moderna, is the government investment through Warp Speed. It took away the financial liability for those companies that participated. So Moderna was told, and again, they were very lucky to get it and all that sort of stuff, but Moderna was told, you start producing even before we know anything about efficacy. And they would never do that. Why would they ever do that? Why would they produce tens to 100 million doses before they knew anything about efficacy or safety if they were going to be on the hook for that? So that we took away that financial liability. Not only did we take the liability away for producing it, but if it didn't work, we took it away for getting rid of it as well. So that's really what put us into this position, which I think is a pretty impressive one. I'm going to, my 18 minutes are up. So I'm just going to head towards the end slide to give proper time for the other speakers. We're not going to spend that much time talking about whole killed vaccines. Happy to do that at another point. And then again, go to a summary about the different advantages and disadvantages of different vaccine types. So again, the type of vaccine, the whole killed, it's inexpensive. So what does whole killed mean? It means I take a virus and I expose it to radiation so that it can't proliferate anymore. Or expose it to chemicals so that it can't infect it. It can't infect and proliferate in a host. It can infect, but it can be processed and seen by the immune system, but it can't infect. So they're inexpensive to manufacture. They're more immunogenic than subimmune, means that maybe some more side effects. The disadvantages, again, more side effects, and they're not as good as the live attenuated. What does a live attenuated mean? It means that I have a virus, like a polio virus, that in me would cause damage and disease. But if I take it and I treat it and I infect cells in my lab with it, and I passage it from one cell to another cell to another cell, it accumulates certain mutations in it that make it not as infectious as is the regular virus. And we don't do this every time we need to make polio. We've done this once, and now it's set. Okay, it's inexpensive to manufacture, highly immunogenic. Risk reversion. There's a risk of reversion to virulence. That's very, very small. But we don't give it to immunocompromised patients. The subunits have fewer side effects, but they're less immunogenic, more expensive to manufacture. And the antigen carrying vectors, which we really didn't talk about, but is part of the AstraZeneca, they're as immunogenic as live attenuated, but a little safer and expensive to manufacture right now. They're not as well developed as the first three categories. Let me just end here with the vaccine guidelines, and I know that we're being recorded so that Max will be able to put that up. Let me thank you for your time and pass it back to Max.
Thank you very much. We will go on. Thank you very much. I'm sorry that we had to cut short your presentation, but hopefully through questions we'll be able to elicit some more information. So we will turn next to Dr. Trombka. Thank you.
Thank you to Bikur Halim for putting this program together, and Rabbi Rosenbaum and Max. I also want to thank my IT staff, Aaron, for helping me with my slides. Otherwise, you have to just look at me the whole time and that would be boring. Okay, this is for people who get the Where, What, When publication that comes out from Baltimore. This is a letter that was in the a letter to the editor from a couple years ago. It said, to the editor, when my children were young, I took them to the pediatrician for all routine health assessments. They were given all vaccines on time. I never missed even one. I never questioned why I was giving them each vaccine. My children never had any reactions to any vaccine. I see that people now are starting to ask questions and decide for themselves what seems medically best for themselves. Now I am a grandmother. I hope that my children do not follow the same path as I took. I hope they don't just give my grandchildren vaccines because the doctors recommend them. I am wondering, are vaccines really necessary? And she signed it, Questioning Grandmother in Baltimore. So I would like to use my portion of this, of the panel and answer Questioning Grandmother's question. First, I would like to tell her, good question, Grandmother. I'm very, very glad that you asked. I think part of the reason you're asking this question is because vaccines are so efficacious that we don't see the diseases that we're protecting from. So it's a very common question that people ask. So my title of my talk is vaccines. What have you done for me lately? So there is a lot of talk about herd immunity, which is kind of the responsibility of the community to vulnerable members of the community. But I think people also need to realize how much vaccines help them, and in addition to helping everybody else. And that's what I'm going to focus on. Okay, just one, I would say, less scientific explanation of how vaccines work. Jonathan, this will just sort of summarize and make more tangible your excellent talk. But I like to think of vaccines as kind of a look-alike to the specific disease that they prevent. The vaccine has the same characteristics of the disease, but not the part of the disease that would actually make that person sick. So basically, when someone gets a vaccine, their immune system sees what it thinks is the disease and makes antibodies to it, and it stores those antibodies in its memory. So then if that person should later on encounter that disease, the antibodies that are in the memory of the immune system are at the ready, and they prevent you from getting that disease. Now, sometimes a vaccine can take care of this with just one vaccine, but many times you need more than one. And the reason for that, and to put these vaccines in a series, is because the first introduction of the vaccine would prime the immune system, and you would make, let's say, antibodies that would prevent like 80%, give you 80% protection. After a certain interval, when you get the second of that series, then that immunity would be bumped up to, let's say, 95%. So that is where the word booster comes from, because the subsequent doses of vaccines kind of boost the immune system. That's why you've heard on the news that one of the companies for the COVID vaccine will be, both of them are two-part series. One of them is 3 weeks apart, one of them is 4 weeks apart. And that is simply to boost the immunity to a level where the protection is even greater than if you would have just got one of the shots. As far as how these intervals are determined in the COVID vaccine and all the childhood vaccines, this is done through years of, or through research about what actually works best for each particular vaccine. Now, besides the interval and the boosting, the other consideration is the age of the immune system when the vaccine is given. And for an example, sometimes the immune system is just too immature to respond to a specific vaccine. So the measles vaccine, for example, if you give it to a baby and then you test that baby's antibodies, it will be 0 because the immune system at that young age just cannot respond to that particular vaccine. So a baby cannot get a measles vaccine until age 12 months. It just doesn't help. And that is the concept of herd immunity, that the way to protect that unimmunized child is to have people around them not have measles. Sometimes it works the other way, where being young helps you. The HPV vaccine, which is a cancer prevention vaccine, that is more effective if you're younger. We give that vaccine around 9 or 10 years of age. We know if we give it before age 14, it works better. The immune system responds to it better. And so under age 14, there's only 2 doses in the series. If someone would wait till they were older than 14, they would need three vaccines to get the same protection. Okay, so now I am just going to briefly mention some of the common childhood vaccines and how questioning grandmom has helped her kids by protecting them with these vaccines. So the first M in MMR stands for measles. Measles is a terrible disease. The younger the person is that would get measles, the more fatal it is. It's one of the most infectious diseases. It's even more infectious than COVID. I'm not a numbers person, but the numbers to remember about the measles vaccine is very easy. If you have been immunized with the measles vaccine, you have 100% protection. So if you have been immunized and you are exposed to measles, you are 100% protected. The other number is that if you have not had the measles vaccine and you're exposed, you have 100% chance of contracting measles. As we said before, who will die from measles, the younger, the more vulnerable. So it really is worse and more fatal for babies. And again, if the vaccine is given at age 1, it doesn't work if you give it under age 1. That means vaccinated people protect those who are too young to receive the vaccine. Because of the effectiveness of the measles vaccines, measles was eliminated in the United States in the year 2000. This was not the case worldwide. So there were still measles outside of the US, but because of our very good vaccine rates at that time, there was no more measles here. Now, unfortunately, the rates of vaccination fell in several pockets of our country, and there was an outbreak in the early 2000 with the exposure from, I don't know if people remember Disneyland. There was a big outbreak from someone who came in from another country with measles, infected a lot of people there. That was brought under control, and then reemergence in 2018. Unfortunately, in most of these cities in Orthodox communities, because the rates of vaccines had fallen. Baltimore, Detroit, Minneapolis, Rockland County, that's Muncie, New York. There was a case in Baltimore of a kid who was not vaccinated, came down with measles, went to the doctor's office. Doctor said, diagnosed measles and gave the parent instructions. These were the instructions. Keep your child's fever down. Measles can reach temperatures of 105, 106. Keep your child drinking. Keep your child well hydrated. If he looks sick, can't drink, you can't get the fever down, here's our emergency number. He's going to have to go to the hospital and be admitted. And the last piece of advice was you cannot take him out for the next 10 days because he's highly infectious. If you take him out and people haven't been exposed to measles, they will catch it. This could spread like wildfire. Now, this was, like I said, 2018. It was the end of March. People probably may remember, but what also happened in our world at the end of March 2018 was Pesach. And the mother, I assume, heard the instructions from the pediatrician, but the part about staying inside for 10 days, that struck her the hardest. And so on the way home from the doctor's office, she went to 7 Mile Market to do her Pesach shopping. And everybody in that store, and it was packed, was exposed to this kid with measles. So here is what I want to give a shout out to questioning grandmom, that being that she immunized her children, if they had been in that store with their own children at the time, they were safe. People in that store who had problems with their immune system, who weren't vaccinated, who were babies, those people were at high risk for getting very sick. AT. Sorry, I might need my IT staff here for a second. Everyone take a break. No. Yeah. Okay, the other M is for mumps. Mumps can be a very uncomfortable disease. The virus attacks certain areas of the body. It can make you have fever. It can attack the salivary glands. People that had mumps had swollen faces because of the salivary glands being infected. It can lead to deafness, meningitis, swelling of the testicles and ovaries, and sometimes death. The point I want to give another shout out now to questioning grandmother, because before this vaccine, the MMR was licensed, and that was in the 60s. Mumps was a very big cause of male infertility. And we don't think about that now because we immunize against this. But back before the vaccine, it was a cause of infertility. So I want to shout out to the grandmom. Maybe she wouldn't even be a grandmom now if she hadn't given her kids the mumps vaccine. Okay, the other R is in the MMR is for rubella. Rubella is a virus. It can make you pretty sick. But the reason we immunize against rubella is not necessarily to keep people from feeling sick from the acute vaccine, the acute infection, but it can infect, if a pregnant woman should get rubella, the unborn child could be born with congenital rubella, which is a terrible disease. They can be born with serious birth defects, liver failure, deafness, blindness, and if they make it out of the nursery, they are pretty much affected for their whole lives. So here's another shout out to grandmom for protecting her future grandchildren by immunizing her kids against rubella. Okay, people have heard of the DTaP, the DTP. I'm just going to talk about the P part of it, which is for pertussis, which is whooping cough. It's a terrible disease. It is worse the younger the person is that has it, and in babies that get pertussis, it basically causes asphyxiation. They lose their ability to actually take breath. This is, people may have heard of this in the past probably 15 years, the Tdap, which is a reshuffling of the letters for different amounts of the tetanus and diphtheria and pertussis components of the vaccine, is given at age 11, but now we've been giving it to pregnant women. So when their newborns are born, They are protected from pertussis by nature of the people around them. And everyone in the household of a new baby also gets a Tdap. They call that cocooning because you're making a cocoon around the newborn, not to expose the newborn to this potentially fatal disease. Okay, polio. Everyone's heard of polio. We haven't seen polio in this country since 1979, but it is still active in different parts of the world. It causes paralysis of muscles. If it affects the muscles of your legs, that person is paralyzed. If it affects the muscles of your chest wall, that person can't breathe. Everyone's heard about the iron lung that they used to use before the invention of respirators that would move the chest wall so people could breathe if they had polio. I will just say in my own personal experience, my mom, who grew up in the 40s and the early 50s, she once mentioned to me that every fall when she went back to school, she would always look around her classroom. She said there was always 1 or 2 kids that didn't come back because polio is a virus that thrives in the summer months. And there was always a kid or 2 that contracted it over the summer, and they would not come back to school because they were either didn't make it or they're paralyzed. Okay, people have heard of chicken pox. A lot of us have had chicken pox. We don't think of it as deadly, but it certainly can be. I want to go back. Okay, never mind. It's fine. Okay, so there were a few hundred cases of deaths from chicken pox in this country every year, and it was mostly for, I mean, certainly otherwise well children could die from it, but it was mostly from kids that had a problem with their immune system. Maybe they were on a medicine treating another condition like cancer or another rheumatoid arthritis, medicines that we use that hamper the immune system. And if you get a childhood illness like chickenpox, it would cause them death. But in our immediate experience, people, if you have natural chickenpox, even if you recover, which most of us did, it always lives in your nerve root of your spinal cord, and it can be reactivated in different times of your life. Like when you get older, if you have a debilitating illness, it can reactivate from the nerve root where it's basically camping out for the rest of your life. And that is what shingles is. It's reactivation of this varicella virus. We see that when we give kids the vaccine now, that their chances of getting shingles is it's not 0, but it's almost 0. So that is another thing that we don't necessarily think about as a benefit of giving this vaccine. Okay, so I want to say another thing to questioning grandmom. When you're giving a vaccine, you got to a little bit think ahead. We talked about the mumps with infertility, polio with paralysis. Meningitis is a bacteria that can kill someone in a few hours. If you're lucky enough to survive it, almost 0% of people come out of it the way they were before they got the illness. Usually the consequences are loss of a limb and deafness. HPV is an anti-cancer vaccine. Chickenpox we already talked about was you're protecting against shingles. Rubella we talked about protecting against in utero infection that could be devastating to a newborn. I just wanted to say a few more words about perspective. Again, we don't really have the perspective of these vaccines protecting us against these diseases that were so awful because we don't see them. We don't think about them. We're not afraid of them. We haven't seen them. And we don't know from them. the fear of these is just, not really on our radar, but they're there. And we have to keep our guard up and keep using the vaccines. There was an interesting study that came out a number of years ago where they asked pediatricians, let's say you have a patient, they say, I'm only getting one vaccine. That's it. I'm only willing to take one. You pick which vaccine I should take and I'm out of here. And so they found in the study that if they asked pediatricians who trained in the 60s, that pediatrician said, oh, you do not skip the polio vaccine. I cared for people in iron lungs, and my patients were, that survived, they were paralyzed, they walk with a brace the rest of their lives. It's devastating. You got to take that one. If they asked pediatricians that trained in the 70s, they said, oh no, don't skip the MMR. That's the one you need to take. That is, I took care of, I saw mothers at the bedside of kids that, that succumbed to measles. I was in the NICU, the neonatal ICU. I took care of babies with congenital rubella. It's terrible. You got to take that one. If you ask people like me who trained in the 90s, we would say, you got to take the Haemophilus vaccine. That's a vaccine that prevents a bacteria that causes epiglottitis, which is a swelling of the airway. I myself took care of intubated kids from, that had epiglottitis from this illness. Also was a cause of meningitis in young people. If you ask pediatricians that trained after me, they would say, oh, you don't skip the pneumonia vaccine, the Prevnar. That one you have to take. I remember being in the PICU, that's a pediatric ICU. I took care of it. Otherwise, the kid was healthy. A week before I took care of him, he was, playing soccer and doing his thing, and then he caught pneumonia, and he developed a complication of pneumonia called an empyema. It's like an abscess in the lung. That kid, he didn't make it. I will never forget that kid. Do not skip the pneumonia vaccine. So it's all about, what you've seen and, where you are. These vaccines are effective, and they protect us. To kind of shed some light on that, let's say Jonathan's lab comes up with a breast cancer vaccine, and it's effective and it's safe, and it hits distribution, and you can go get it. Like which one of us would not jump in the car with our mothers, our sisters-in-law, our sisters, our aunts, our female neighbors? We would go, our daughters, we would go stand in a line for hours to get that shot. And when our daughter would say, Mom, I don't want a shot. Mom, I don't want a shot. We would say, honey, yes, it'll hurt for a second, but this is for your future. I don't ever want you to have this. And let's say, as promised, the vaccine works. People take it. There's no breast cancer anymore. We don't see it anymore. I mean, there's still breast cancer if you didn't take the vaccine, of course, but we don't see it. And a decade goes by, and 2 decades go by, and then your grandchild has a kid. And this is another point to questioning grandmother. And you're with your granddaughter who has a child, and she says, oh, we have a pediatrician's appointment tomorrow. She's due for the breast cancer vaccine, but I don't think I'm going to take it. I don't know anyone with breast cancer. That why would I do that? That's necessary. I don't want to put something in her body that's not necessary. So questioning grandmother, what you would not rest until you convinced your granddaughter to give her daughter that vaccine. So I think that is all I'm going to say. And thank you again.
Thank you. Thank you. We go next to Dr. Fishman. We may need a bit more than 12 o'clock to wrap up with some of your questions. So please hang in there if you can. And we'll now move on to Dr. Fishman. Thank you very much, Dr. Trombka. Thank you.
Thank you. So, hi, I'm Eliot Fishman. And unlike Dr. Trombka and Dr. Schneck, I have a Ph.D. I'm not a medical doctor. The only time I really ever go by Dr. Fishman is when I'm leaving a message with a physician and I want him or her to call back. So I'm gonna go ahead and share my screen. Okay, hopefully you are looking at a PowerPoint presentation, is that right?
Not yet, not yet,
Not yet?
not yet. Try again.
Here we go.
Yep, yes, we see it now. Thank you.
Okay, good. So Max, I wanted to thank you and thank Bikur Cholim and Shomer Emunah and the other sponsors. I think when you were pulling together this presentation initially a few weeks ago, we really thought this issue was looming, potentially months off, and now here we have actual, vaccines applying for emergency authorization from the FDA. So these community decisions and family decisions are potentially upon us pretty soon. And I want to talk about some of the policy aspects of something that's really, I think, the running theme through this whole set of presentations, which is our communal obligations and public obligations around getting a vaccine, not just in terms of it being safe and the right thing for people individually and for individual families, but really the impacts on everybody else around us. So I wanted to start by just thinking about the centrality of consent in our healthcare system, right? And this is a pillar of our healthcare system that we take for granted. Dr. Trombka, right in that letter from questioning grandmother, her phrasing was, as my kids are making their own decisions about what's right for them, and that assumption that is how medical decisions are made is very important in our healthcare system. I think it is more true in the United States than in other countries. And it is really important and valuable that is so central in our healthcare system. And it's particularly, I think, important for us as observant Jews that we have the opportunity not just to decline medical care, but to insist on medical care in situations where that may not be the recommendation of medical professionals. That we as observant Jews have the opportunity to consult with a Rav and potentially push for medical care at the end of life. That's a very central thing. Really something that is very valuable and worth fighting for in our healthcare system. And yet when it comes to vaccinations, that is not the way our healthcare system works. That is, every state in the United States mandates vaccinations for children to attend school. There's often typically mandates on all sorts of frontline healthcare workers around vaccinations. I'll just spend a bit talking about vaccinations for children. Those of you who have kids have, of course, experienced all the paperwork around enrolling kids in school or in camp or in daycare. It's a matter of state law. And the logic here is that not just that parents have a responsibility to kids and that the state has a responsibility to kids, but that one family's decision impacts potentially many other families or an entire community. And just thinking about the spread that Dr. Trombka was just talking about from outbreaks. So this map shows the different kinds of exemptions that states allow from vaccine mandates. And what I think is notable here is, first of all, relatively few states allow exemptions from anything other than medical grounds, or of course, every state allows exemptions on medical grounds. Most, but not all states allow religious exemptions, and those would typically go to, for example, Christian Scientists or other people who have broader religious objections to modern medical care. And relatively few states allow any sort of exemption other than those. So there's a case, Jacobson versus Massachusetts. You'll see I took the trouble to point out that Jacobson was not a Jewish person. This is the foundational case that allows states to mandate, and in this case, it was actually a criminal penalty to mandate vaccination. The logic of this case was that, yes, of course, our Constitution is based on individual liberty, but that liberty doesn't mean you're never restrained by the state for reasons of the common good and basic reasons of public safety. And actually, this case is one of the most cited constitutional cases in constitutional law because it is vaccination becomes the foundation of states constraining individual liberty for purposes of public safety. So I'm not talking about vaccination mandates to suggest that anybody is going to legally mandate that we get COVID-19 vaccinations. I do not anticipate that at all. But just to illustrate how much there is a strong community interest in high vaccination rates. And in general, I think we've all had a very difficult and sobering lesson in the math of transmission rates and how variations in transmissions going a little higher or a little lower with COVID-19 can actually lead to hundreds of thousands of additional people contracting the disease or the transmission rates going down. And turning that dial a little up or down can make a huge difference over time. That is particularly true with vaccination rates. So now I'm going to change topics and to talk about policy around vaccine distribution. And in particular, just to, as a starting point, as Dr. Schneck described, these molecules are not particularly simple, particularly with these vaccines. It's going to take months to ramp up the supply so that everybody can be vaccinated. And particularly there will be logistics issues around distributing and storing vaccines. Notably, the Pfizer vaccine requires deep freezing, and that will present some significant challenges around storing that vaccine. So how's this going to work? The Centers for Disease Control is going to set the overall national guidelines. I think everybody involved in this whole system is going to be looking to the CDC for guidance and instructions. The manufacturers of the vaccine are going to handle the shipping themselves. It's notable that Pfizer has already put out that they are taking unusual precautions around the shipping of their vaccine, understanding that this is new and that people need the assurance around the security that they're taking with this vaccine. So here's a quote from Pfizer about how they're tracking the individual boxes. And then in Maryland and in every state, you're going to see both state and county officials making the more detailed decisions around the supply and distribution of the vaccines, including things like in the beginning, when not everybody can get the vaccine, who qualifies and who does not. I'll go into that in the next slide. It's going to be probably a lot of new people administering vaccines. It won't necessarily just be physicians, and training all those new people who are administering the vaccines. And I think we will likely see, and this is the plan, I'll share a link in my last slide, we'll likely see Montgomery County actually doing some direct vaccination, same way that we've seen Montgomery County doing some COVID testing. So this is from what used to be called the Institute of Medicine. It's now called the National Academies of Science, Engineering, and Medicine. and they put out a proposed tiering or phasing around vaccine distribution. So this is not official. It is a prestigious body that is making this recommendation, and it's a I think a reasonable expectation around how the vaccine distribution is likely to be phased. And as I mentioned, I think there'll be federal guidance that nails this down, and then it will be up to the state and the county in terms of how people document whether they belong to one of these groups, and specific definitions, who's considered a healthcare worker or a first responder, or who's considered an essential service worker. Those kinds of specific definitions will be handled at the state and local level. So these are some policy resources. The first two are federal, around the development of the vaccines and the plans around distribution. And then the third link here is Maryland's vaccine distribution plan. This was up, all the states shared the vaccine distribution plans with the CDC. So this is the federal posting of Maryland's plans. And then I also included, because it's likely that we are going to have these decisions carry over into a new presidential administration, what the Biden transition team has put out to this point around COVID-19, including vaccine distribution. So with that, I am going to stop screen sharing, and I look forward to your questions.
Thank you very much. We have one more presentation by Rabbi Rosenbaum. Thank you very, very much. And then we'll have questions. Hang in there. Thank you.
Thank you. Thank you very much to all the presenters. This has really been, I think, a wonderful program. And of course, as always, thank you to Max Redman for his tremendous efforts. Really briefly, I want to just touch on 2 points from a halachic perspective. So one point is, we know there's a verse in the Torah of Nishmartem Ma'od L'Nafshosechem, that we have a directive from God to be very diligent about our safety. And of course, we know all the things about the mitzvah to be fit, and that even v'chai bahem, that if heaven forbid we have to desecrate the Shabbos to protect our lives, we should do it. But I think it's a fair question to ask oneself. So where's the pasuk in the Torah that tells me I should or shouldn't get a vaccine? Is it, do I have to wait for every doctor on the planet to tell me I should get the vaccine? Do I have to wait for 100% certainty that there's no risk of anything and every doctor to tell me that? Maybe some rabbi will tell me based on a verse. What am I supposed to do? So, and I think that's a very fair question. And the general approach among halachic authorities is one is supposed to rely on scientific and medical consensus. In other words, when you think about it, all the things that we do that are hopefully guided by science and medicine, we're relying on consensus. As Dr. Fishman touched on, there are definitely times where the doctor we might be talking to, the hospital, might not agree with our theological approach, and there might be a question for a rabbi. But I think on this one, the Torah and the medical profession are all on the same team. The question is what needs to be done to preserve our health as best as possible and preserve communal health as best as possible. If the general medical consensus is that through the different procedures that Dr. Schneck discussed, that a vaccine is appropriate for the general population to take, then the halacha would be that we have to follow that medical advice. Of course, people could have unique specific circumstances, and for that we need to discuss with our own specific doctors. But as a general principle, it would seem that the halacha is we follow general medical consensus. And the general medical consensus is wrestling with all the questions that we'd have about these different issues. And if they come out and they say, for all the questions that we might have, it still makes sense to take the vaccine, that presumably on a religious level would be the directive that we should take. That's one thing I would just like to emphasize. And the other thing is, I think it's so essential to recognize this is not, as has been touched on, but from a religious perspective as well, this is not only about me and my family. This is about my community, my country, my world. And if it's been decided, once it's been decided that the appropriate thing for communal health is to take this vaccine, then I have to do it, unless I have a unique medical personal circumstance that makes it uniquely dangerous for me. That story that Dr. Trombka shared about the mother walking through 7 Mile Market with the measles issue before Pesach, I'm sure mortified many of you as much, if not more, than it mortified me. It's very important to recognize that if there is an ability to take a vaccine and a person declines for no good reason, in a certain sense, that individual from a halachic viewpoint is endangering others around them, maybe not to the same scale, but it's not that far off conceptually from the person walking through 7 Mile Market with the measles. There are halachic deciders who compare the person who refuses to get a vaccine for no justifiable reason to a rodef, a person who's actively endangering other people. One more topic that I thought was very interesting that I saw referred to in an article. So let's say I say, I'm not endangering other people. I'm only one person. If everyone else takes the vaccine, surely there'll be the herd immunity, and I won't be endangering anyone. And what I saw cited from at least one halachic authority is a very interesting principle. And he argued that anyone who's doing or not doing something, that if everyone else would do or not do the same thing, would create communal danger, that individual has no right to say, well, let everyone else take the vaccine and I won't. If conceptually at a communal level, everyone is obligated to take a vaccine, or it's essential that the masses take the vaccine, then indeed anyone, unless they have unique personal medical circumstances, halachically should really be taking such a vaccine. If I could just add one more thing, and this is more from our community vantage point, I'm sure it's true for every community out there. I and many of you know of various people who won't even have the option of taking the vaccine because of whatever their own personal medical issues are. So it only raises the essential nature of all of us who medicine would recommend to take the vaccine to do so, and just to think of how much we owe it to ourselves and all those around us. And this is a mitzvah as well. And with Hashem's help, thanks to so many wonderful people in the scientific and medical professions, as examples of which are our wonderful panelists today, Hashem should help us protect ourselves so we can all continue to live together and serve him so well. Thank you very much.
Thank you very much, Rabbi. We have time for a few minutes, and we can go over noon for those of you who can stay longer. We have a couple of suggested questions. We can start, and if you have more questions, please send them to the chat. So one question is, what about the cost of coverage? So the question is something like this. Can you talk about insurance, maybe directed to Eli Fishman if he feels he can answer it. Can you talk about insurance coverage and patient cost sharing for COVID vaccines and administering the vaccine? How will this vary for patients on Medicaid, Medicare, marketplace plans, other commercial plans, and people without insurance? If you feel you can answer that question, fine. Go to it.
So it should not be an issue initially, because first of all, there was congressional action on this in the springtime in terms of making sure that federally regulated insurance is going to pay for vaccines when they're fully approved. When the vaccines are going out on under an emergency use authorization, there's also going to be, we'll have kind of single payer healthcare, Medicare for all when it comes to paying for vaccines initially. And I actually just shared a link in the chat window about what Centers for Medicare and Medicaid Services are telling providers who may be administering vaccines about how to make sure that they can bill for them. So I don't think I can provide an assurance that there won't be questions or bumps in the road in terms of making sure that all of that payment goes okay. The same way there was, for example, with COVID testing, where it was all supposed to be paid for, and yet some people still sometimes got bills associated with it. But I think I can provide an assurance that if for the vast majority of people, that won't be an issue. And if you do get a bill, that you can challenge that bill, and ultimately that that should get resolved, and you won't have out-of-pocket liability.
Okay. Okay. Thank you very much, Ellie. So we have another suggestion that somebody address the question that has come up periodically about the possible impact of vaccination and the probability of autism as a consequence of vaccination, of the measles vaccination. Can somebody address that? Maybe Dr. Trombka?
So that has been disproven decades ago. It was first proposed in the early 90s by a guy in England, Andrew Wakefield, who showed some association with autism in the MMR vaccine. It was later proven that his data was fabricated. The funding for the study was funded by families with kids with autism, and it was just not based on science. In the meantime, as everybody knows, there was a big uproar, and in England, they actually stopped giving the MMR, or a lot of people chose not to take it. And when they went back and looked at the rates of autism from after the people that didn't take the MMR, the rates were the same or even greater. So we have known for a very long time that that is absolutely not true. Andrew Wakefield was subsequently, his license was taken away. He was actually put in prison. He's still out there doing damage, preaching to groups that want to hear what he has to say. But I will say this, fear, we don't know what causes autism, and fear is a very strong emotion. So the fear is still there, even though the data is not, but nobody in the respected medical community believes that there is an association between any vaccine and autism.
Thank you, Lynn. Okay, I have we're past the noon hour of our program, but I have a question that several of you can perhaps answer. I'll put together a lot of questions here. What is the long-term effects of the various COVID vaccines? And somewhat related question about impact or effects is mercury or thimerosal added to the Moderna and Pfizer multi-dose vials being used? And can someone explain the difference between the mRNA vaccines versus other vaccines and their safety long-term? I guess the question here is, what are the potential side effects of various things in the vaccinations? What do we know? And so it goes back to safety and efficacy, but especially the safety issue. So maybe Dr. Schneck can respond to that to the extent he can. Thank you.
Sure. I can take a stab at that.
Thank you.
First, just in terms of the autism, let me just shut the door because Michelle's also listening. In terms of the autism, Dr. Beeler also posted some very helpful information from the Hopkins website about that, but Dr. Trombka pointed out that that's been entirely debunked. Thimerosal is not being used. The Moderna vaccine is a single dose vaccine. So thimerosal would not be used in any sort of single dosing regimen. I haven't looked and seen what is being used in, if anything like thimerosal is being used in the Pfizer. But again, there was no link. Thimerosal has been eliminated. There's really no link between thimerosal and any problems, but because of because just safety precautions and concerns about it's more important for people to be comfortable and safe and know that what they're getting is the best product than to use a preservative like thimerosal. And so most vaccines went away from that. I believe there's some flu vaccines that are multi-dose. In other words, there's a vial where there are 10 doses in it or 100 doses in it, and they're given to people. And Lynn, you can correct me if I'm mistaken. And I don't know what preservatives they use in that sort of setting, but most of the vaccines now are single dose. And again, the Moderna certainly will be single dose, and the Pfizer will not be, and I don't know what they're using. I think that that was part of the question, right? The mRNA, and again, Lynn, if you want to hop in, please feel free. The mRNA is, it's a little different than what we've seen before, and maybe there's concern about that because it's a little different. But mRNA is everything. Our bodies rely on mRNA every day, every second, every nanosecond, that's what we do. It will not cause things like, it's not an RNA virus or going to cause things like they can sometimes do in, go into people's cells. There's no ability to do that. So I also wouldn't worry about that. It'll be around for a little bit of time, enough to get the immune system up and revving, enough to make the proteins, those modified proteins that I talked about, get the immune system up and revving and recognize it, and provide them the protection. But I don't see any issue associated with mRNA. It's, again, surprising from a scientific perspective that the two first that come out use this sort of platform, but guys like me will spend years and years studying why that's the case, and hopefully be able to help more people with more diseases in the process.
Thank you very much. Okay, so mRNA is one of the vaccines that recently issued and determined to be pretty effective by the vaccine manufacturers. There is a question out there. I don't know if it's Rabbi Rosenbaum has already answered it, but if he wants to take a crack at it. There are rabbis who oppose vaccination according to their understanding of halakha, and the conflict between individuals or minorities advocating for their perspective and the safety of their larger community and world. How do you resolve that conflict?
My guess is there are doctors who say different things also, and lawyers who say different things, and accountants who say different things. I think it's, I'll just tell you that there are numerous shilas that I'm asked about all kinds of issues having to do with medical care. And the first question I ask the questioner is, what did your doctor say? And obviously there are many doctors saying things. That's why I was talking about the medical establishment and general consensus before. But I feel very strongly that many halachic questions, there are sometimes issues where our religious views might deviate from some of the motivations in the medical field. That could happen sometimes. But generally speaking, for questions relating to our health, the first question has to be, in my opinion, what does the medical profession say? I can only tell you what I think, and I'm pretty sure that what I said today is representative of the vast majority of the rabbinic world, to the best of my understanding.
Thank you very, very much.
Thank you.
I think we've run through all the questions that have come in so far. As I said, we will attempt to have periodic updates, different programs on different aspects of the experience that has brought a lot of this world to its knees. But God willing, we see light at the end of the tunnel, and we'll be able to make some progress moving forward. Also, it'll take a bit longer than any one of us want. We are making a recording of this program, and we'll make it available on the various listservs out there. So thank you very much for participating, and look forward to suggestions for future programs and to your support in this effort. And please support Immigrate Washington, which has been an important source of health education programs in our community, and the local synagogues that make this possible by advertising it. Thank you very much, all of you.
Thank you.